So I'm going to introduce our speakers today. I'm going to introduce a speaker from Universal Financial Systems. So starting our roundtable today is George, who is the COO of UFS. UFS is a business partner of the Riverside County Medical Association. They specialize in medical billing and collections. RCMA members receive a complimentary insurance and patient collection performance analysis and discounted service pricing. If you would like more information, please contact George directly. And for that, I will hand it over to George.
Hi, everyone, and thank you, Mitzi. We're happy to be part of this roundtable. And I say we because today I do have one of our professional biller and coders with us to answer any questions that might pop up that we can't help with or I don't have answers for. As we said, today is a roundtable to discuss, some of the things that we've seen as it relates to COVID-related services or billing issues or trends. We won't necessarily go into COVID testing. I'd say most of our clients don't necessarily do the administration of COVID testing, although there is codes and so on. We can talk about that another time. But we want to talk about certain updates as it relates to traditional billing and collections and accounting and performance throughout these times. One of the things that we wanted to bring up, one of the first updates is a diagnosis code update. As you can see from this slide, there are a number of updates that are COVID related. The first three are more as they relate to reporting purposes. These were active as of January 1st of 2021. And this is a result of the COVID-19, and they want to understand the different reasons patients are going in there. Of course, the bottom three are actual diagnosis codes, specifically the pneumonia due to coronavirus disease and so on. So these are just codes to be aware of. You can go on the CMS website, they'll explain in detail when and how to use each of these codes, but we just wanted to bring this to your attention. Next slide, please. Now, as it relates to, I say COVID billing, but this is more telehealth billing during COVID. There is a correct way to bill out a telehealth visit. And in the early days, I'd say the first month or two of the pandemic, about a year ago, there was some confusion as how to bill it. People were putting, or many payers were asking for place of service 2, which indicates telehealth. And then they introduced Mod 95, which did the same thing. But then they finally settled on the correct way of billing out a telehealth visit is to put your traditional place of service, let's say it's an 11 for an office, along with a modifier of 95. Now, I will say that sometimes there are exceptions, and this is a very unique case-by-case basis. We found that, for example, and I know this is for Riverside County, but we have clients all over. In Orange County, we have a medical group, St. Joseph, and St. Joseph require place of service 2 with Mod 95. So not understanding why that is, they do ask for it that way, but it's how it's going to get paid. And so we would urge you to, of course, by this point, I think many of us have figured out how to bill with telehealth correctly, but it's those medical groups that sometimes have very unique requests. Next slide, please. So changes in telehealth and copays. So this is more for non-COVID related services. When there are COVID related services, there are no fees, there are no copays or anything else. But this is as it relates to other services. And what do you do to collect these copays when it's telehealth? It's an extra layer or another additional task for you. And traditionally, what we say is you always want to collect your copay ahead of time, right? But how do you do it when it's a telehealth visit? Well, hopefully you have an administrator or a front desk person who is making these appointments and confirming these appointments, and that would be the appropriate time to collect that copay, right? Call the patient, you're confirmed for next week at 3 o'clock, and by the way, there's a $35 copay. Let's go ahead and accept it now. There are certain instances where the provider doesn't have the luxury at this time to have a front staff or administrator, and sometimes, I mean, the last thing a provider wants to do is ask their patient for money before they render a service. So of course, there's always the ability or the option to collect afterwards. So render the services, and of course, when the EOB arrives, a bill will go out to the patient. Now, there are certain, when it comes to telehealth, there are some unique exceptions as it relates to what is covered and what is paid and what's not paid. For example, and many of these exceptions expired on January 31st of 2021, but I'll give you two small examples. Aetna, for example, with some of their behavioral health plans, they did waive copays and fees for those services. Another example is, again, through Aetna, some of their Medicare Advantage policies for primary care specialists, they also waived copays. So it is a very mixed bag. It's hard to figure out kind of rhyme or reason of what is waived or what is not. Of course, the EOB will explain everything at the end of the day, but copays, telehealth, collect them up front if you can. Otherwise, just send a statement out, collect it on the back end. Next slide, please. So outside of telehealth and COVID-related items, just a little FYI, as of January 1st, and this is a very nice little update, Medicare did increase some of their fees and reimbursement rates for a lot of the, of course, most highly used CPT codes. So that is really great. I think these rates here are reflected of Riverside County. You should see a rate increase across other payers because many do base their fees on Medicare standard. But you'll see, compared to last year, most of these have increased by roughly 20%. The 99215 actually went up 23% or so from last year. So that's a nice little bump and bonus for all the hardworking providers out there.
And would you suggest, George, that they download those fee schedules in their billing systems or their practice management systems to reflect that?
Yeah, absolutely. Yeah, absolutely. Some billing systems are updated automatically. Sometimes even your charge rates are reflective of that, the 2 times Medicare or 3 times Medicare. But now would be an appropriate time. All of this information is available on the CMS website. You can download the fee schedule, comb through it, look it up manually, but it would behoove you to update your rates so that your charges and everything reflected accordingly. Next slide, please. So one of the biggest issues, and it's something that we're still working with our providers for, is making up for lost revenue. Depending on the type of provider and the services that they rendered, some of our providers and our clients had to shut down or limit their business. At some point, everyone was affected. And there are some offices that actually had to shut down completely for 1 or 2 months at a time. So what do you do when there's no new business coming through the door? Well, you work on the old business, and this is a good time to catch up. It's inevitable that everyone is going to have some amount of AR, and this was the time to really catch up on it. We have one provider who typically, let's say, brought in $100,000 a month, went down to 0, but because we were able to work their AR consistently and catch up, we brought in 50% of his revenue without him actually working. And that is working denials, working AR, working on your collections, pushing out patient statements. And I know this is kind of a tricky subject matter, is sending patients to collections during this time. And I'm sure there's a story for everything, but whatever you can do to boost that revenue and make up for lost business, now's the time to do it. And of course, encouraging telehealth. It's of course understandable that patients don't want to travel and are hesitant to go into a doctor's office, but encouraging that telehealth element, we just talked about it. I mean, reimbursement rates are the same as even coming into an office, and it's actually a little bit easier. It might not be the same level of service or intimacy with being with your doctor, but it's definitely an option to keep your business going during these times.
And George, I was going to ask another question. So I love all the good information that you're giving out here. I wanted to kind of ask about, you had brought up trying to make up for lost revenue. Some good ways to do that through telehealth is the annual wellness visits. And then maybe you could talk a little bit about transitional care management or chronic care management.
Yeah, absolutely. A lot of these codes, like transactional care management or chronic care management, these are services that are already being rendered by a provider, whether they're conscious and knowing of it or not. We had one provider who was going to skilled nursing facilities, going to hospitals, making rounds, and basically being the quarterback for these patients' daily care, and not understanding or not even knowing that without having to do anything else on his side, we could be billing a chronic care management code for qualifying patients. And most of the patients that he had were qualifying, that had hypertension and some other chronic disease. And the requirements weren't that great for chronic care management. But we were able to go through and bill a year's worth of CCM coding for him, and he had no idea that this was just money sitting out there. And of course, with TCM as well, patients that are being discharged from the hospital, the doctor sees them within the 7 days or 14 days. There's definitely a code for that. And this is, as you said, it's finding these additional CPT codes and ability to bill for something and services that you might already be doing, but maybe your billers aren't aware that they can bill that out for additional revenue.
Fantastic. And so also when we're talking about our AR and our aging reports and some of our financial summary reports, what would you suggest that folks are doing right now, especially getting ramped back up into everybody coming back to work and more patients coming in the office, and we're getting all busier, thank God. What would you suggest for people as far as their monthly reporting? I've got some thoughts, but I'd like to hear your thoughts on some monthly reporting that people should be taking a look at each and every month.
Sure. And I'll just tell you the reports that we give our clients. And we have kind of like the general, I'd call it a general bundle that we believe that every practice should be running these types of reports. And then depending on the specialty or the doctor and the requirements, we can also run additional specialty reports. But these are, of course, claim submissions, so charges as they relate that are based on date of service, charges based on the date of posting, so that you can make sure that are we getting out all the claims that the doctor is, all the services that are being rendered by the doctor in an efficient amount of time. Of course, payments that are being received, and AR, and when I say AR, we're looking also at the aging buckets. There are certain benchmarks and certain ways that your AR should look. And sometimes the AR could look overwhelming, but the numbers make sense. And of course, a lot of it depends on your charges and your fee schedule and everything else. Somebody might have $1 million of AR, another person might have $300,000 of AR. And in reality, it's the same amount of money floating out there. They're just inflating the adjustments and the charges. Now, another thing that's really important as you're running these reports is to be able to have a trailing history of the prior months. So you can see, how are we doing this month relative to last month, the month before that, and so on. What is influencing a change in payments? Is it because the doctor took 2 weeks off 3 months ago and we're feeling the result of that? Is it because the office shut down, less patients? Is there some big billing issue, a clearinghouse blockage? By being able to look at these trailing months and trends, we can also do something that's a little bit more advanced, is we can start doing forecasting. So if you, and we do this for a lot of our clients, we'll look at how revenue is collected, how much revenue from the same month, the prior month, the month before that, services are being paid today. and we create an algorithm that basically lets us forecast. So we'll be able to see, you know what, over the last 4 months, 5 months, this is what you've billed out. We expect, based on our performance and forecasting, this is how much money you should bring in by the end of this month. And that allows for planning and budgeting and so on. It also allows you, as I said, this is a perfect example of working your AR. If you see that charges have been low last month and the month before that, and you can expect that this month might be a hit, you want to put some extra focus on AR to make up for that difference. So it limits some of the surprises you have. And when it comes to medical billing, it is like a big slow moving ship, and it takes months to turn that around. And a slight change, you'll see the difference from that many months to come.
Okay. All right, go ahead, George. Sorry.
Oh, that's I think that's all we have for now. We're going to stand by for any questions. Like, as I said, I have Rebecca here with me. She's one of our professional billers and coders. So if there's any specific questions, hopefully we can help you through that. And if it's an answer we don't have today, we'll definitely take your information and get back to you.
Okay, raise those hands, guys, if you have any questions. We really want to hear from you. It's probably relevant to what we're talking about right now, or somebody else is having something going on in their practice that relates to what your question may be. So we encourage that interactive, just as if we were in person. Remember, when we're in person, we used to raise our hand all the time. So we want that to happen. All right, so I'm going to now introduce Gina Fick, who is the Vice President of Quality for Inland Empire Healthcare. So I'm going to hand it over to you, Jenna.
Great, thanks everyone. Hi, I'm from IEHP and really focusing in the area of quality. So I'm excited to talk to you today about telehealth and how we are really kind of seeing health plans and payers really respond to telehealth over the past year. So next slide. So we, as we've been talking, this has been the theme. We keep hearing a lot about telehealth. It's really increasing in use, and we are seeing that in the Inland Empire, in our primary care provider offices. We are seeing more and more evidence of our providers adopting telehealth, which is really exciting, and we really support that as a health plan. We do think that it's actually a great tool, a unique tool that could be leveraged to help keep patients up to date on some of our preventive care services that are really a big part of the value-based sort of incentive structures that are kind of more and more kind of appearing with our primary care contracts. And we really also align with what CMS and DHCS has been communicating around kind of allowing for that parity of those services, and really keeping that really open and flexible for providers who want to really expand into this space. So next slide. So at IEHP, really, one of the big themes that we were wanting to promote during this time of the pandemic is not to lose sight of some of the really important outpatient services that our patients still need. So there are some things that the state really, has set as priorities. Those include the timely immunizations and really keeping our kids healthy and safe. And so thinking about how can we do these preventive care services in a safe way. And this is really where telehealth seems to be like a really good response. Also, as mentioned earlier, behavioral health care is another big area of telehealth adoption. And a lot of our patients with chronic conditions need to be continually monitored during this time. And so again, telehealth has been a really nice option to keep patients at home, but still being able to keep them connected with their care. Mitzi mentioned earlier with a question about the transitions of care, transitional care services, and that's actually another really big priority area as well. Lots of patients really still need that support and follow up after being discharged from a hospital stay. And so these are really areas kind of as a whole, where IEHP is a health plan and really kind of the theme we see with other payers as well. These are important areas that we want to continue to really be thinking about how can we support the patient's needs and keeping everyone safe in the process. So kind of as a response to that, IEHP did provide some initial and continuing to support kind of guidance and feedback on how we could leverage telehealth during this time, and then also patient-reported biometrics, because that has come up as part of the conversation, especially when you're managing patients with chronic conditions. How can you leverage that information during a telehealth visit? So next slide.
And Janine, I'm just going to stop you right there. And
Sure.
I just want to remind folks, I know that IEHP has some really great tools and resources on their website as well. Is that correct?
We do, and actually it's in my slide deck later on. You'll see the link to that website as well, Mitzi. So yeah, great plug for that. And we encourage our providers to visit it as often as they need it. So let's go to the next slide. So what I'm going to do is sort of just highlight some of those key areas and kind of what are some of the things that we've kind of put out there as messaging to our primary care network, but then also kind of have, fine-tuned over time. So, really looking at in the pediatric space with the well care visits, really, we want to continue to support, our patients being on track with the Bright Futures guidelines. We've been watching very closely the AAP recommendations. And what we see is that there are really, some really great options available to consider using telehealth kind of as a hybrid approach to keeping our members and our patients care continuing during times of a pandemic. So we can actually see that services can be offered in person when needed, as well as virtually through telehealth. Next slide. So one obvious, thing that we have to do is, continue to keep our little ones on track to getting fully vaccinated in those first 2 years of life. And that's a real big priority at the state level. And we've really wanted to encourage that to continue during the time of pandemic. And of course, that has to be done in person. So we recognize that is a special population that will really want to continue that diligence. Next slide. And then when we start looking at the older children, we do see that then this is where telehealth then could be leveraged. Again, we really recognize that the provider ultimately needs to determine for each patient the clinical appropriateness of a telehealth visit versus something that could be done through in-person or telehealth. But what we do instruct or encourage our providers to do is to bill for each visit offered. So if you're going to be kind of leveraging that hybrid approach where you'll be doing a well care visit, some components done through telehealth, and then a follow-up visit at a later time for in-person components, we are instructing our providers to bill for both visits. And again, being clear that, which one is done through telehealth versus which ones are being done in person. And I have an example on the next slide that kind of walks us through some of those components. And so this slide just shows some examples of some things that could be offered through the virtual option versus what would need to be done during an in-person visit. And we would encourage, again, our providers to document each visit separately. Next slide. So the next slide here provides an example of some of the code sets that you could be thinking about documenting so that you could maximize earnings on certain quality programs that at IEHP we have to offer, but as well as state programs under Prop 56. And so this slide is kind of providing some of those examples of when conducting a virtual visit, you could document kind of all the components that are listed here on the left-hand side, along with what codes would be available or appropriate to submit alongside those components being offered. The very last column here shows which programs would be sort of supported from a financial perspective. So we have quality incentive programs for our primary care network, and that's noted as our GQP for P. But the state also has their own incentive programs currently in place with Prop 56 funding. And so those are called out under that programs column. The next slide. Again, for those components that need to be done in person, we would instruct our providers to bill those components separately when the patient does return to the office. And again, we're showing here sort of an example of all of the different components and the appropriate codes that we would encourage our providers to be documenting for reporting in order to earn those incentive dollars that are noted in the programs column on the right-hand side. So this is just a good reference page for anyone who is looking at how to sort of maximize earnings on these sort of services. Next slide. So kind of transitioning away from pediatric care and into more of the adult care, one of the other big areas that we were encouraging our providers is to really think about how they can support their patients who are being discharged from an inpatient stay. And so again, telehealth has been proven to be a really great tool that could help keep our providers connected to their patients. So some of the things that can be conducted over a telehealth visit for this follow-up transitional care kind of a visit would include things like medication review, reconciliation of the discharge and outpatient meds, a needs assessment for the patient and all of the things that they may need to be safe at home, including care management, any specialty care needs, home health, DME, and any testing that needs to be ordered, as well as an assessment of their ability to care for themselves when they're at home and instructions on how and what to do if their certain symptoms worsen. So these are some examples of components that could be done through telehealth for that follow-up visit. Next slide. And so IEHP's provided some guidance on how to bill for that or document that for reporting, and so that they can get credit for some of their quality performance measures. And so we note that in our global quality program guide, and I had that sort of highlighted here on this slide. And again, we are encouraging that modifier 95 in particular. And thank you to our earlier presenter to clarify that kind of the more recommended kind of practice at this point is to keep that place of service 11. IEHP has been open and we'll accept sort of either option. That place of service 02 would still work in our system, but we do provide that guidance to our providers. And again, this is available on our website, which I'll show you that link in a moment for those of you who would like to see more about that program. Next slide. So transition to those patient-reported biometrics. So, during these telehealth visits, sometimes there are components of the visit that we'd like to collect. We would traditionally collect during an in-office visit, but we can now do it through these patient-reported mechanisms. And so collecting information like height and weight could be done through a telehealth visit, and we would require that the provider record and date that information in the medical record in order for that to be allowed for billing or reporting. Next slide. Controlling high blood pressure. This is another area where we look at, providers are more and more getting this information through member reported or patient reported readings. And so again, we allow for that for reporting of our measures in quality. And the really important point here is that, again, it needs to be recorded and documented in the member's health record. And so there are some specific guidelines that we provide on how to record that and bill it, which I think is on our next slide. So for anything that's done through a telephone visit, this is an example of the codes that would be acceptable, but they must be also then billed along with the reporting codes for the level of the blood pressure reading. So the diastolic and systolic codes are there listed. That would need to be submitted along with the telephone visit codes. Next slide. Here is our resource page that we have available, and really anything related to the pandemic, resources, any communications that we send out to our provider network is archived and saved here in this plan update section of our website. And so this link is something that you could bookmark so that you can check in and see if there are any new updates. And it does have a lot of really great resources for our providers. And I think that's all I had. Any questions?
I think we do have a question in our chat. If you can unmute, please.
Hi, this is Gabriel.
Hi, Gabriel.
Hello, I do have a question regarding the telehealth visit code plus the P4P. You were on the slide of controlling blood pressure in there, and I noticed that you require a telehealth visit code in addition to the P4P CPT Cat2 codes. Would those two codes be included on the preventive visit code or the office visit E&M? So we're talking about 3 codes now.
Could you go back to that slide for me? Maybe it's like 2 or 3 slides back.
There.
This one here, yeah.
Yes. So I see there's some CPT codes on the left, and there are P4P CPT Cat2 codes on the right.
Correct.
If those 2 are included in the are those 2 required in the office visit note? I'm sorry, in the office visit E&M?
So, this is one option. So this would not be a limitation. So you don't only have these telephone visit codes. We highlighted these are sort of newer codes that providers may not typically use when they're doing telehealth visits. And so this is really kind of a highlight of, we now have these telephone visit codes that we're recognizing as acceptable for reporting. However, if you typically use an E&M code to document your visit with the patient, even during the telehealth mode, then that would be acceptable. So so really the codes on the left that are noted as these telephone assessment or evaluation codes would be one option. Another option would be your E&M code. Again, you would need to report the modifier 95 that it was done telehealth, so that we could record that the visit occurred. The codes on the right are your reporting of the level of the blood pressure reading, which of course is also important. So you really need to have 3 codes in total, some sort of procedure code that demonstrates the visit occurred. And so I have the telephone visits here as an example. You could, of course, use your E&M codes that you would be typically using as an option instead. And then you need those 2 reporting codes, the diastolic and the systolic, in order for that kind of full bundle to come across as a visit that happened telehealth with the capture of those reporting elements. I hope that answers your question. Let me know if that's not clear.
So just to summarize it, it's going to be, so this is allowed, that an office visit with a modifier 95 plus systolic and diastolic codes for P4P, correct?
That would work. Yes, that is correct.
Thank you so much.
Yes.
Great. Thank you, Jania. I want to go back to Mary Lou. I think we had a little bit of a connection problem, and if you still had your question, we would love to answer that for you, Mary Lou. So we'll unmute you and you can ask that. Are you there? No.
I did unmute her, but I'm not sure if she's still on. It said that.
It looks like she is, but can you unmute her?
I tried. She hasn't.
It didn't work. Okay. All right. Well, Mary Lou, if you have got that, please just feel free to email us and we will get your question answered. Anybody else have any more questions? No? We'd be more than glad. We've got plenty enough time. We're running a, really good timing here for our webinar.
Mitzi, can I ask a question?
You sure can.
So I was noticing, like, they say modifier 95 or place of service 02. I've been doing it with both. Is that a problem?
For IEHP, that would be allowed. We've actually really kept it very flexible as far as options, because again, in the beginning of the pandemic, there was really not a lot of clarity around what would be the most appropriate. So I think now that we know, more providers are sort of leaning towards the place of service 11 and that modifier 95, we'll accept that, but we'll also accept the 02 place of service and the 95. That's okay. So we've kept it really flexible, but I do think it depends on the payer. And so I'll let George chime in as well on that.
Are you there, George?
Yeah, sorry about that. I was sitting there muted.
Okay, Zoom.
Can you ask that question again? It's as it relates to the place of service and mod 95 and when to use it. Was that the gist of that?
Well, when I do my billing, just because there's some places that want the 02 and some places that want the 95, I've been putting 02 and 95 modifier.
So what we've been finding, I would say with about 99% of the payers across all of our clients, they're accepting place of service, let's just say it's the office, so place of service 11 with mod 95. You will find that some payers are still paying with place of service 2, but one of the things that we found is that there are some payers that are denying with place of service 2. So to keep it safe, we're doing POS 11, 21, whatever the place of service was with mod 95, and then we have a small exception report for those payers who do require place of service 2. That has kind of become the standard for quite a while, the place of service 11 or whatever it is with 95. But like I said, you will find those exceptions. One for us is St. Joseph's. There was, some of them it's no rhyme or reason. We have a couple of United Healthcare plans that denied for 11 but paid on 2. But that was just like one exception with a couple of claims. But 99% of our other United Healthcares are paying with, 11 and 95. That's been our experience.
Because sometimes the doctors are not in the office doing the telehealth. So would we still be able to put 11?
Right. I guess in that sense, yes, you would do a place of service 2, right? If they are truly not in the office.
Yeah, because we have to help with not having so much staff in the office. We'll have a provider in the office and then a provider at home doing telehealth.
He documents it as he's in the office.
Okay, one of the things that we've seen with our doctors is that when they are doing a telehealth visit from home, they use as if they are in the office, place of service 11.
Oh, okay. Okay, thank you.
Yeah.
Okay, great. And we do have, I do have a question in the chat. Do you know if there is any end date for using telehealth?
No, we have not heard any end dates on our side. As we said, some of the little exceptions have been popping up. For example, as I said, January 31st of 2021, some of the telehealth exceptions for copays and things like that have ended, but we do not know of any foreseeable deadlines of telehealth going away. But it's ever changing.
Jania, do you have anything to add to that?
I would echo that. Really, I haven't heard any definitive, end date. And we are really encouraging, I think just in general, health plans are wanting to kind of keep that open as a mode for delivery. So at least at IEHP, we're not intending to have an end date anytime soon, or if ever, really is kind of where we're heading.
Okay,
to
so it
keep
looks
it.
like, Nisha, it sounds like one of your patients got a letter from an insurance to stop telehealth, and I would just ask that you and I work offline on that, because I would like to take a look at that letter if I could. Okay, we've also got a hand raised from Antonia.
Yes, hi.
Hi,
How are you?
doing great.
I have a question for George. I don't mean to get off path with the telehealth, but I did note I heard something in his earlier part of the presentation when he was talking about streams of revenue and additional streams of revenue, and you mentioned TCM. Our providers here provide CCM care. We're a nephrology specialist, so we do some CCM care, and we do have patients that will crash, go to the hospital, and need that follow-up after they've been discharged. And so I know with the CCM rule, it's kind of like the first provider. It's only paid to one provider per month. Is that the same type of policy or guideline with TCM as well?
Yeah, yes, you're correct. It is the first provider to report it is the one who gets paid.
Okay, got it. I just wanted to get clarification on that. I've been doing some research and it's kind of been conflicting information I'm getting. So
Right.
Awesome. Thank you so much, George. I appreciate it.
That's a great question. We've also got another question in our chat. Do I still use modifier 95 with CPT codes 99441 through 99443? Is mod GQ used anymore? George, I'll let you take that.
Sorry, I was going to say, I'm going to have to take that one offline. I don't have an answer right now.
Okay, well, we'll definitely get that answer to you, Jonathan. No problem. We'll get it out to you, okay? All right, this is great, you guys. I love these questions. It's fantastic. And again, if you just have anything else to share that can help folks on the call that you're doing in your office, we want to hear that too. It's not just about the questions. You guys might have some suggestions that would be good as well. So we're open to all of those. So let us know. All right, let's go to the next slide. So I'm going to just kind of talk about the telehealth resources that we have at the Riverside County Medical Association and the San Bernardino County Medical Society, and also the California Medical Association. I just want to make sure that you guys kind of understand how to get there. So this is a slide that kind of gives you exactly how to get to the telehealth page, and then you can go ahead and download all the information that you need from there. We have a whole telehealth resource center on our webpage. Again, one-stop shop. So if you are interested in any of that, please go and check it out. There might be some useful tools for you there. Next slide. And then this is going to just be really good to know who to call and kind of what we handle. And so obviously in the reimbursement operations and practice management arena, it's going to be me, and I would love to hear from you all. And then on down the line, you're going to get a copy of these slides at the end of the presentation. Marquita will send those out to you. Along with our survey, please, you guys, when you do the evaluation survey for us, it would really be helpful. And we'll get those slides out to you as well. So one last chance, we'll give you a few more minutes of your life back if nobody has any more questions or wants to add any comments, suggestions.
I wanted to add really quickly on the 99441. I understand the question because these are telehealth specific codes. I guess my question would be, and I don't necessarily have the question about needing the modifier there, but my question would be, why are we billing out a 99441 to 99443 during this time where you can actually be billing out a 99213, 1415 and get higher reimbursement, use the modifier? Especially because they've lifted the requirements for, or they've reduced a lot of the requirements for what telehealth is and means of it. So it might behoove you to change it and rebill it from a 99441 and 43s and so on to an actual office visit.
So that's great information. It looks like Jonathan actually signed off already, George. So and that's okay. That's great for everybody else as well. So we'll go ahead and get that information out to him. You and I'll let you reach out to him and tell him that. Okay, so we want to thank all of you guys for joining us today. That's fantastic. I hope you really liked the Roundtable interactive webinar that we did today. I think it's a little bit fun. So I want to thank the Riverside County Medical Association, the San Diego County Medical Society, the California Medical Association, and most definitely our presenters today, George and Jania, for all that great information. We're right here for you guys, so give us a call. Don't struggle, pick up the phone. Thank you so much, everybody. Have a great day.
Thank you, guys. Bye-bye.
Thank you.